So, supply chain. I'm not sure how many of you guys even know you have a supply chain. But is it a blessing or a curse? But you got to learn how to use it to your advantage. Again, these are my disclosures. Dealing with competition in healthcare is really problematic. As you can see from the last talk, there's a lot of different drivers that everybody's having. But realistically, we need to be able to work together so that we can actually start to save money and do what's right. How do you stay competitive in vascular care? Well, what's slowly going away is a referral-based security. Mail's thrown away, letters are e-filed and not read, dinners are not attended and can be illegal, gifts are illegal. Separating yourself by being the best is sometimes very difficult to communicate. What's not going away or coming up is the first of the 3 A's that we had since we were medical students, and that first is access. Economic advantage, patient experience, and convenience. And in fact, they don't want McDonald's, they want you to be working like McDonald's. If you look at what happened in the beginning of time from healthcare delivery, it was actually just kind of cutting things off, making diagnoses. There wasn't a ton that we could do. And then we turned into the technological era where we had lots of things. We had Army Swift knives, we had operating rooms, we have catheterization laboratories. We have everything we can do to try to make us look glorious as to what we do. I'm not sure our outcomes really have changed that much, but we certainly look a lot better doing it. Why don't we have socialized medicine in the United States? That'd make it a lot cheaper, right? Well, if you really look into this and see why, it's because this is what Stalin said. If you want to control a person's health, you control the person. And Reagan said there's no better way to get socialism than to do it with socialized medicine. So that's why we don't have it in the U.S. But what we do have is just outstanding costs. Our average spending health per capita is way too high. When Mike Backrack was still working in the operating room, these were the kind of, I'm just kidding, Mike. These are the kind of bills you used to see. Look at that. The operating room fee was $5. But look at the Medicare fraud. Professional discount, $8.85. You now go to prison for that. Things have changed. What other things cost in 1942? A car was $1,100. Gasoline was 19 cents a gallon. Bread was 9 cents a loaf. The stock market was at 119. The average annual salary is $2,400. The minimum wage was 30 cents per hour. Now, what about 2009? If we had kept the inflation that we've seen in medicine in the basic everyday things that we buy, a dozen eggs would cost $85, a roll of toilet paper would be $25.67, a pound of butter, $108, a pound of bacon, $129, a pound of coffee, kind of close to today, $68. What things cost in 1942 compared to what they are in 2009, look at the difference. And that's what we've done to healthcare in the United States and around the world. We should be ashamed. But what of the current system? We act like there's a bottomless pit, ladies and gentlemen. We are broke in the United States. We're broke in the world. We have an elderly population, and we're throwing tons of money at people, and we have our kids to support. We're going to have such a huge deficit that our kids are going to be in debt until their kids and their kids get around to it. Our medical costs are absolutely non-sustainable. We are over 20% of our GDP. If you look per capita, again, it's much higher than the rest of the world, and even theirs are too high. If you look at the total federal budget, most of that's on healthcare. It's much more than defense. Healthcare delivery then is under pressure. There's economies of scale. You're seeing physicians being employed, and if you think that isn't a plan to then control us, you're crazy. And there's a volume to value focus, which if you're at my hospital and is your hospital the same, it's primarily looking at that bottom dime. But we have to be less a part of the problem. We do unindicated procedures as physicians. We play for restenosis sometimes. I can't believe I was at a vascular surgery meeting, and the vast majority of the audience, when there was a good plain balloon angioplasty result on a long lesion, said that was good enough. We're doing the highest reimbursed procedures when not needed, unnecessary testing, dealing with procedures, deals under the table related to device use, et cetera, et cetera, et cetera. So we all should be ashamed because we then allow everybody else to say, well, if the doctors are doing it, we as hospitals can do it. They're a Ponzi scheme. And if you look at industry and pharma, they're making huge profits. So we as physicians have to be a driver for change. This cartoon is too brief, just look at it in your cartoon thing. Supply function does a lot of things. They help you get your devices. They help you have materials so that you can do your work. They do a lot of things, inventory control, logistics, a lot of things like that. But the reality is there's historically separated from reimbursement. I remember when I told them, well, there's a pass-through code for drug-coated balloon. They said, we just deal with acquisition. We don't think about the reimbursement. Little insight into the important stuff. Pacemakers are all the same to them. Promotions are driven by cost savings. They have the 2.5-year rule on administration. In 2.5 years, I want promoted or I'm out. So they never do anything but cut costs. Trying to build programs is very difficult in that time frame. If you negotiate negotiating is a big part of their job in supply chain. Little insight into research and relationships. They have no idea about your doctors, your other companies, research, those kinds of things. And they actually have little insight into advancements. Remember, the only thing they can get from a company is what's on IFU. They can't look at off-label because that can't be presented to them. Now, there's upsides to a functional relationship with supply chain. You can be more competitive with the payers. If you can get the price on your devices down, you're more competitive in the future with your payers. There's less emotion. I mean, oh my gosh, how many different scoring balloons do we have to have on the market at a huge amount of money with no freaking data? Is that crazy? But we're buying it all the time. Well, then drive down the cost with your supply chain. We can get the physicians out of awkward moments by working through supply chain and not only by yourself. You can help drive more uniform procedures to help with procedural evaluations and outcomes on a local level. If you're all doing the procedures somewhat similarly, you can measure your outcomes locally in your community. If you're all doing something different, whatever you want to do, you can never figure out what's going on. You can never adjust for inequality. There's plenty of commodity opportunities, as was noted earlier. Working together helps them make better decisions. They want to make good decisions. They don't want to hurt people, but they don't have the insight not to do that. Decreased waste of expiring devices is decreased waste. Less unexpected is like the equipment you wanted isn't available anymore. Help us build a partnership between the physicians and institutions, and since so many of us are employed, you got to get that. And it can work towards getting a percentage of savings invested in your section if you work it right. Here's just an idea of what we look at our compliance. We're part of the Accelerate project. So we have this on a monthly basis. We tell where we're at with our commitments. And we only do commitments for commodity items. But you can see that for our pacemakers, we're 99% effective, buying the same, everybody's using the same stuff. Coronary stents, we're at 98. Coronary bear stents, we only had 2 used. It's kind of crazy. PTCA balloons, you can see just down the list that we're getting there, and we've only been doing this for about 8 months, so we're already getting there. Summary, there is non-sustainable cost of today's healthcare. If we don't want to play a major role in reversing this, patients will be hurt. Working to develop insight with supply chain will be best for everyone. Pick your battles to help win the war, and that's better care and cheaper care in the United States and around the world. Thank you.